Okay. Recording started. Again, slide share. Okay, fine. So, though X-ray is a commonest investigation regarding lung imaging, but always it is not possible because sometimes patient is so sick, it is not possible to take him or her to the X-ray department. And there are some pathologies where we find Schiller sign. Schiller sign means merging of the pathology and merging of the organ, so that it is not possible to identify pathology, whether it is like in X-ray, you will find brighter images of the pathology, that is pneumonia or consolidation of the lung, and also the fluid, that is proliferation present in the pleura. So that sometimes it is difficult to identify in X-ray whether it is fluid or solid mass in the lung. In that cases, this is the only way to identify the pathology. It is the ultrasound. This is the superiority of the ultrasound in case of lung imaging. And it is very cheap, and you can do it by the bedside of the patient. If you have a portable ultrasound unit, so that you can bring it to the bedside of the patient, and you can do ultrasound very comfortably. And there are few pathologies that can be identified in ultrasound very, very well. So that ultrasound is very useful investigations in lung imaging, especially in some selective pathologies. So today we are going to discuss about those. So in this slide, you can see these are the transducers we can use, or we are usually used in lung ultrasound. And this one is the convex probe. This one is a linear probe. This is high frequency, and this is a sector probe or phased array transducer. This transfer usually is used for the scanning of the heart, and this is used especially to superficial structures, and this is used usually deeper structures. All these three transducers will use in lung scanning. So in specific diseases, I will again discuss about the probe, which one will be used for those cases. So this is the protocol of the ultrasound imaging for the chest pathology. একটু microphone off করেন please, mic or sound off your microphone, noise আসছে প্রচুর. Okay, so a patient should be in supine position. You will see this line, that this is zone of the, especially you should say it is a zone. This is anterior, sorry, upper and lower, upper lower. This is anterior, this is lateral, and same in the posterior zone also. So this is upper zone, lower zone, upper zone, lower, upper zone anterior, lower zone anterior, upper zone lateral, lower zone lateral, and back you will get posterior zones. And so how we can identify these zones? The first line, just sternal, whereas sternal line here, this one, this anterior axillary line. In between these two lines, this is anterior zones, upper and lower, and the posterior axillary line and anterior axillary line. In between this lateral zones, upper and lower, and back you will get the posterior zones. So we'll scan here and here, here, here. So after the findings, you will be confirmed about the diagnosis of the diseases. Just see the later one. So, what are the indications of, or what are the diseases, especially we do ultrasound for lung? So, indications, first one is pneumothorax. So, you see, pneumothorax, is the term that defines air collected in between the two layers of the pleura. There are two layers of the pleura. One is parietal pleura, that is attached with the chest wall and the diaphragm, and the visceral pleura, that is attached with the lung. And there is a very thin film of fluid present in between two layers that facilitates lung to to how to say, to collapse and expand. Okay, and it avoids, this film of fluid avoids the friction when during respiration. But when you will get a pneumothorax, this space will be occupied with the air, and severity or symptoms of the patient or discomfort of the patient or dyspnea of the patient is depending on how much air is entrapped into the two layers of the pleura. Sorry. So most of the cases you will see pneumothorax is having a history with trauma to the chest cavity. That means there is a trauma that induces any perforation or leakage into the pleura that will assist air in enter into the pleural cavity. So pneumothorax, and you can identify very confirmly in ultrasound. Then is pulmonary edema. And this is the thing, pulmonary edema, during pulmonary edema, fluid accumulates in the lung parenchyma as well as within the alveoli. You see, this is these two images here. Below, this one is alveoli and fluid present in the alveoli sac. Okay, so when fluid present, then sound beam can go through the lung parenchyma, and this is the idea in ultrasound of lung. Sound beam, now we will see sound beam can pass through the lung, and this issue will be used in case of diagnosis of the pulmonary edema. Okay. This is a pulmonary edema, alveolar interstitial syndrome. Then third one is pleural effusion. This ultrasonography is a very good modality to identify presence of fluid in the pleural space. Okay, and sometimes ultrasound is superior than X-ray, because in X-ray, if you want to find fluid present in the pleural space, it is needed to be present 120 to 150 cc of fluid. Unless you will not get a presence of fluid in the X-ray, because this is the pleural recess, so that when we take X-ray, it is done usually in erect posture. That's why fluid will go downward and it will go into the pleural recess. So the until the pleural recess is filled with the fluid, then it will come here to show in the X-ray film, that is obliterating the costophrenic angle. In X-ray, how we diagnose pleural effusion? Just we see obliteration of the costophrenic angle, but it is not done, or it is not happened in X-ray until there is 110 to 120 cc of fluid is present in the pleural space. But in ultrasound, you can find presence of fluid in the pleural space if it is only 20 to 30 cc of fluid. So clearly it is superior than X-ray. Okay, so that minimum collection of fluid in the pleural space can be identified in ultrasound, and it is done very easily in ultrasound, and you can do it very much comfortably. Fourth one is the pneumonia. Pneumonia is the another pathology that can be identified in ultrasound, and we can do it. So all these three indications: pneumonia, pleural effusion, pulmonary edema, pneumothorax, these are the diseases we can identify in ultrasound. So normal findings of lung sonography. Now we want to see what are the normal findings of the ultrasonography of the lungs and how we can do that. We use three types of probes depending on different pathologies or our need. The probe is kept in the intercostal space with the marker pointing towards the head. That is the longitudinal plane. We'll place our transducer, আমরা আমাদের ট্রান্সডুসার লংগিচুডিনাল প্লেনে রাখবো, পয়েন্টার প্রবের পয়েন্টারটা পেশেন্টের মাথার দিকে থাকবে, আমরা অ্যান্টেরিয়র জোন থেকে শুরু করি। We place our transducer in between 2 to 5th rib and in the intercostal space, because if you place your transducer over the rib, sound wave cannot pass through the rib as because it is bone. So that you have to place your transducer in between ribs, that is intercostal space. Okay, the ribs produce distal shadow, and we'll see it in our ultrasound images. In between two ribs, there is an echogenic line more than 5 millimeter deeper to the probe, which is the interface between the soft tissue and the chest wall. The pleural line, I will show you the pleural line. That is, so when you will find the images in ultrasound during chest sonography, you will see first a layer of the skin and soft tissue, then we will go to the lung, and before entering into the lung you will see the pleural line, and we'll see it in our images. The air uh, in normally aerated lungs এর মধ্যে এয়ার থাকবে, stops progression of the ultrasound beam, and hence the ultrasound image of the lung is composed of artifacts. And we know that very well. And during abdominal scanning, we see a lot of times sound beam obstructed by the bowel gas, and it produces shadow. This shadow sometimes it is very sharp shadow, sometimes it is hazy shadow, depending on the concentration of the air present in the bowel loops. Here, a lung contains air, so that you will see also this type of artifacts, and I am showing you later on. These air artifacts arise from the pleural line depending status of lung, means the way that this lung is aerated, that is normal aerated lung, or consolidated, or containing fluid inside the pleural space, sorry, inside the uh, interstitial space, or in the alveoli. Two types of artifacts can be seen. We see usually these are the two basic things in lung sonography, A line and B line. So we see usually in lung ultrasound there are two lines, A lines and B lines, so that you will see in sonography routinely, especially during lung ultrasound. So now we are discussing about A line. সো অ্যাকচুয়ালি আমরা আসলে যখন আল্ট্রাসাউন্ড করব তখন এই দুইটা লাইনই আমাদেরকে সমস্ত কিছু গাইড করবে। সো এই লাইন দুইটা একটু ভালো করে বোঝার চেষ্টা করেন। যদি বুঝতে না পারেন সেশন শেষে আমাকে আবার প্রশ্ন করবেন, আমি আবার বলবো। এ লাইন্স, horizontal regularly echogenic lines representing reverberations of the pleural line. These are motionless and are the artifacts of the repetition. In two-thirds of the normal lungs, this is the only artifact pattern that can be seen. You see here, there is এখানে বলছে যে this line is due to pleura. You see this is very bright line, and this is coming from the surface, that's why it is appearing very bright. এরপরই হলো lung tissue. Below this line is a lung tissue, and normally lung is aerated with air, so that sound beam will be bumping. So sound beam just come and go, come and go, come and go, so that you will get reverberation artifact. This is called, this one is a aerated lung pleural line. This is pleural line. Then you will see another pleural line here, but it is less brighter than this one. Then again you will get this one, another pleural line. This is called A lines. These lines, this is originally pleural line, these are A lines, and these A lines are coming from the pleural line when the lung is aerated normally. So that in normal lungs, when air present in the lung, then no edema is there, so that you will get this horizontal brighter lines. These horizontal brighter lines are, these are the A lines, and this one is the pleural line, and above the pleura you see this is soft tissue skin, this is skin and soft tissue. So this layer is skin and soft tissue, then pleural line, then lung. So we cannot see the lung because air present inside, so that you will get A lines in case of normal lung. Okay, here we see this is a real-time imaging image. So you see here, this is normal lung, this is not tissue, soft tissue and skin, then pleural line, this is A line. Okay, so you'll see like this in ultrasound. And this image is not so good because depth is not so good. So if we increase the depth, then you will get another A line here. Now we are discussing about B lines. Okay. So B lines are defined as multiple echogenic vertical narrow based line from the pleural line to the edge of the ultrasound screen. B lines are pathological. Says, A line, I told you earlier, is just normal. That will be present in normal line. Okay. But B line, you will not get in normal line. These lines are present when there is pathology in the line. And how you can see here, you see these bright lines coming from this is pleural line, you see here. This is pleural line, this skin and soft tissue, this pleural line, and you see there's some brighter line that coming from here and reaching up to the bottom. So keep it in your mind. So these bright lines are coming from the pleura and goes up to the bottom of your image. So these are the B lines. Okay. And here see in the left side, this is real imaging. And you see here, this is the ribs. This is one rib, and it's coming shadow. Okay. These are the posterior shadow coming from the ribs. And this is these are the B lines. You see these white lines in between ribs. Okay. And two things you should keep in your mind, especially for B lines. Number one, these B lines will be present only in case of a pathological condition. Normally you will not find. And these B lines will come from the pleural line and it goes up to the basal layer, that is up to the bottom of your image. So also here you see it is going bottom of the images. Third one, another one is sometimes you can find a few vertical lines, but these are not going up to the how to say, up to the bottom of your image, so that these are not B lines. So when you will get B lines, these will be brighter. Narrow base means in the pleural line here you will get is narrower, but yeah, when it is going downward it will be broader. You see here, here is broader, but in the where it starts it becomes narrower, but when it goes downward it will be broader. So this is B line, pathologically present, multiple in number, should be more than two. More than two should be present in between two interspaces. These are the things related with B lines. First one, it should be present when there is pathology. Number two, it is narrow at its origin, and while it is going downward, it will be broader, and more than two will be pathological. Okay, more than one might be sometimes. You can see I'm showing you later on. So this is A line versus B line. Okay, and in the left side you see this is the pleural line, and this is A line, this is A line. So this is normal, you can see in the normal line. But in the right side you see this is B line, this is a brighter line coming downward up to the bottom. This here, these are the B lines. So B lines, so this is definitely pathology. And now you can understand, as because normal sound beam cannot pass through the normal lung. Normal lung means normal aerated lungs, so that you will get this type of horizontal A line. But in case of pathology means sound beam can enter into the lung. When sound beam can enter? When the lung should have some fluid inside its parenchyma or inside its alveoli. So this is called pulmonary edema. So you will get these vertical lines, especially in pulmonary edema. In other way, if there is no air, when you can find lungs without no air, maybe consolidation, maybe atelectic lungs, that means lung is collapsed, you will find this type of vertical lines. Okay, so according to your information, that is ultrasound finding, you will be able to diagnose whether it is only uh, pulmonary edema or pneumonia. You can be identified later on. Okay, I'm showing you. So now we know about A line, B line. Now we are trailing about Z line. I told you earlier, you can find some vertical lines, but those are not reaching up to the bottom. Here you see this is B lines. These are vertical lines. coming from the pleural line and it reaches up to the bottom. But here, Z line, these lines are not reaching up to the bottom. Okay, so I got the message from the Google that I have 10 minutes more in my hand, so that when this session will be closed automatically, please don't go away. I will give you again the password and ID for login, please. So these are Z line. These lines are Z line, and these lines can be present in normal lung, especially in pneumothorax can be seen. We can see, but you see here, this is the pleural line, and you can see here this is A line also present here, but not so prominent in like here. That means this lung has air inside, but there is some problem. That's why you cannot see like this. Okay. So these are called Z lines. Z lines are also these vertical lines. These vertical lines are Z line, but these are not reaching up to the bottom of the ultrasound image. But B line, these are the brighter lines, vertical, narrow beam, but not and reaching up to the bottom. That's why this is pathological. So dynamic changes in ultrasound during respiration, and when we will start scanning lung, it is not possible, or we don't ask the patient to holding his or her breath. It is not possible. So patient will breathe normally, and you will do a scan. So what is happening during ultrasound, especially for lung? The pleural line slides. This is very important. You see here the images. You see, just this is a pleural line. You see chest wall. This is chest wall. Chest wall goes this way and pleural goes this way, just opposite direction. Okay, you see here. This is called pleural sliding, and I'm showing you later on the mechanism. So you see, this is chest wall and this is the pleural line. So when the pleura goes this way, chest wall goes this way. So the opposite direction with the pleura. So this is called pleural sliding. You see, the movement is distinctive as the surrounding chest wall structures are still or move in an opposite direction to the lung. This is pleural sliding. The pleural sliding movement is the normal finding in ultrasound. The image best seen in an M mode. Just I'm showing you the M mode ultrasound, as the superficial parietal layers are motionless, as because chest wall is not moving. It's because it is going this way, so we see this is going this way. Basically, this is static or have slight movement during expansion of the chest wall. Uh, and while the area deep to the pleural line appears granular, as the motion of the pleural line is reflected all over this area. This is also known as the seashore sign, just sign synobole. Okay. Just you see this one here, this is M mode tracing, very well. So this one, just see this line. This is the pleural line here. Above pleural line, these images are coming from the chest wall, and this is from due to movement of the pleural line. And here you see this is a line, sorry, this is pleural line, this one pleural line, this is a line coming here. So first disease we are going to discuss, that is pneumothorax. And I told you earlier, pneumothorax means presence of air in between two pleural layer. Okay, so patient position should be supine. We'll go for scanning patient having pneumothorax. So patient position should be supine. Transducer, usually we use linear transfer for the scanning, because as patient has pneumothorax means air present in the pleural spaces, so that sound beam cannot pass through the air, so that we want to see the pleural movement and pleura very well, so that a sound beam coming from the high frequency transducer are more in number, so that we'll get a good quality image, clear image. Okay, so that we use linear transducer. Approach should be anterior and lateral. We scan from anteriorly, patient will be in supine position, but you can scan in through anteriorly and laterally. Scan plane sagittal, scan for 4 to 5 respiratory cycles. So you have to look for 4 to 5 respiratory cycle. Respiratory cycle means inspiration and expiration. One inspiration, one expiration means one respiratory cycle. Okay. What will be also findings? Absence of lung sliding. So very important, you know. Just previous slide. In previous slide, we saw sliding, lung sliding, and in case of pneumothorax, you will not get the lung slide. Okay, and it is understood as because in case of pleurofish, in case of pneumothorax, lung should not have any fluid present inside, so you not get the B line. And you know, sound beam cannot pass through this air present in the pleural space, so that sound beam cannot reach up to the uh, lung parenchyma spatially. But you can find A line, you know, because sound beam is reflecting from the air present in the pleural space, so that you will get B lines. Maybe not so much brighter as in normal lung, but you can find A lines. Transition zone or lung point can be seen. I can tell you about a lung point. Just think, one patient having air in the pleural space. When this patient will be in supine position, what will be the position of the air inside the pleural space? It will be coming upward. That means air goes to upward. So if we place your transfer in the supine position from the anterior chest wall, sound beam will go through the chest wall, then it will get the air present in the pleural space. Okay, so sound beam cannot pass, and you will not see the um, sliding of the pleura. Okay, sliding, that is lung sliding. Lung sliding. Okay, let me show you this slide, then I'm talking about you. So this, see this one, then I'm discussing these things. Keep it in mind. So transition zone, you see, pneumothorax techniques, uh, high frequency tensor will use linear transducer, multiple interspaces from 2 to 5th rib. Just here we'll see here, so multiple interspaces will use, and your position will be uh, sagittal. Okay, and 4 to 5 respiratory cycles will observe. And here, this is the thing, here you see, uh, this is the lung, and you know, there are two layers. Okay, I'm fixed here. Yes, see here. So this is the lung covered with visceral pleura. Here, visceral pleura will be covering the surface of the lung. Parietal pleura is covering the inner wall of the chest. Okay, so that this space is the pleural space. Normally, there is a thin film of fluid present in this space that allows movement of this lung during respiration. But what is happening during and when sound beam, normally when sound beam pass through the anterior wall, so it comes through the pleura and reflects from this. So during respiration, where lung moves, so this image also moves. This is called uh, sliding of the pleura or lung sliding. Okay, but when there is pneumothorax, that is air present inside the lung pleura, thus you see. Just you see, just air coming inside the pleural space. Just you see, yeah, this is see, just now this is air present inside the pleural space. So what is happening? The sound beam is coming here, and then it cannot pass through the air present in the pleural space. So sound beam cannot reach up to this visceral layer, so that you will not find the uh, lung sliding. Okay, and this is the mechanism. In this case, you will not be able to see the lung sliding. And as because sunbeam cannot pass up to this layer, so if there is any fluid present in the lung, you cannot find the B line. Okay. And definitely you will see the A lines.